All right, so once we got the history laid out, we shift gears a bit, moving from talking to looking and measuring. Starting with the general survey, the GS. This feels like where the subjective starts becoming immediately objective, that first impression the moment you walk in the room.
That's exactly it. The general survey is your study of the whole person, and it starts the second you lay eyes on them. It gives you an immediate sense of their overall health. And we look for four main things, kind of all at once. First, physical appearance. Do they look about their stated age? Are they well-groomed, clean? What's their body structure like? Second is behavior and mental status, often called level of consciousness or LOC. Are they alert and oriented? We usually check AO times person, place, time, and situation.
Okay.
What are their facial expressions showing? Relaxed, stressed, grimacing. And their mood, are they interacting appropriately or maybe seem depressed or have a flat affect?
And the other two relate more to movement and, well, comfort level.
Right. Third is mobility. How do
Yeah.
they walk their gait? Is their base of support stable? About shoulder width? Is the walk smooth? And their posture, are they standing tall or slumped over? And fourth, pretty obviously, signs of pain or distress. Are they grimacing, guarding a body part, moving in a limited way? Are there clear signs of trouble breathing or heart issues?
Wow, that's a lot to take in all at once, especially when you first walk in and things might be happening fast.
It becomes more intuitive with practice, really. But you have to consciously learn what normal looks like first to spot the deviations. And remember, that baseline shifts with age. For an older adult, you might expect sharper body contours, maybe some kyphosis, that forward curve of the upper spine.
Mm-hmm.
Their gait might naturally be a bit wider for better balance. It's not necessarily a sign of distress like it might be in a younger person. You have to factor age into your normal.
Good point. Okay, so from that quick visual scan of the GS, we move to the hard numbers, the essential measurements or vital signs. Let's talk clinical nuances here. Temperature first. Oral range is about 97.5 to 99.5 Fahrenheit.
Yep. And we need to know what can bump that temp up, things like hormones, stress, being dehydrated, and what brings it down a cold environment, certain surgeries. But here's a really key clinical point. Why do we avoid rectal temps in patients with known heart problems?
I remember this. Something about a nerve.
Exactly. Stimulating the vagus nerve when you insert the thermometer can trigger a vasovagal response. That can dangerously slow the heart rate. For someone whose heart is already compromised, that's a risk we just don't take.
Wow, okay. So a simple procedure has a potentially serious risk tied to the patient's history. What about pulse? Expected is 60 to 100 beats per minute. How critical is judging the strength?
Oh, it's crucial. That strength scale 0 for absent, 2+ is normal brisk, 4+ is bounding, tells you about the quality of their circulation. Being able to tell the difference between a normal 2+ pulse and a bounding 4+ pulse, which might suggest they have way too much fluid volume, gives you a quick insight into their cardiac output and fluid status, even before you grab the BP cuff.
Speaking of the BP cuff, blood pressure. This one feels notorious for errors if the technique isn't right, especially the equipment.
It's probably the most common source of error, yeah. The cuff bladder, the inflatable part, has to cover about 80% of the arm's circumference. Too small a cuff, you get a falsely high reading. Too big, falsely low. And since we base treatment decisions on these numbers, accuracy is just paramount.
Right.
And yeah, you absolutely need to know the stages. Stage 1 hypertension, for example, is 130 to 139 systolic or 80 to 89 diastolic. Got to know those cutoffs.
And we can't skip orthostatic hypotension checks. Those are specifically needed sometimes, aren't they?
Correct. Orthostatic hypotension, that's defined as a significant drop in blood pressure when someone stands up. Specifically, a drop of at least 20 millimeters of mercury systolic or 10 diastolic within 3 minutes of standing.
Okay, and how do you check that properly?
It's precise. You have the patient lie down flat, supine for about 5 to 10 minutes first. Measure their BP and pulse, then have them stand up, wait 3 minutes, measure BP and pulse again while they're standing. If you see that significant drop, your clinical brain needs to immediately start thinking why. Is it sudden fluid loss, maybe bleeding somewhere, or dehydration from vomiting? Or could it be a medication side effect, like their blood pressure meds are working a bit too well? That assessment starts right there with those two measurements.
Makes sense. Okay, finally, let's talk pain. It's that subjective symptom we try to quantify. The absolute core principle, repeated everywhere, is pain is always whatever the patient says it is.
Yeah.
Self-report is gold standard.
Absolutely. And to manage that self-report systematically, to really understand it, we use the PQRST framework, which, as we mentioned, you've likely already touched on when getting the HPI. So P is for provocation or palliation, what makes it better or worse. Q is quality, what does it feel like? Sharp, dull, throbbing, burning. R is region or radiation. Where exactly is it? Does it spread anywhere else? S is severity, usually on a 0 to 10 scale, but also how bad is it really? Does it stop them from doing things they normally do?
Mm.
And T is timing. When did it start? Did it come on suddenly or gradually? Is it constant or intermittent?
So by using that structured approach, BQRST,
Yeah.
we make sure we're not just reacting to a number on a scale, but actually understanding the person's experience, which ties back to that anti-oppressive holistic approach we talked about.
Precisely. It's about collecting the data thoroughly, understanding the context, cultural, personal, environmental, and treating the whole individual, not just chasing a symptom. Hashtag attrib2.
So wrapping up this deep dive, it really shows that getting good at health assessment isn't just about knowing facts from a book. It's about applying these structured ways of thinking. We saw that with the nursing process for prioritizing and the general survey for that immediate objective snapshot.
Right. And we kept coming back to communication, didn't we? How the whole thing relies on it. And maybe just as important as knowing what to say is knowing what not to say, avoiding those barriers like judgment or false promises. That's key to getting honest information.
Definitely. Which leads us to a final thought for you to consider. We established that the accuracy of the whole health history really hinges on the client being reliable. The sources even suggest we might need to check info with secondary sources sometimes. So think about this. You're doing an initial assessment on a brand new patient. What if you can't verify some basic biographical data they give you? Maybe their date of birth seems off, the address doesn't check out. What's the immediate implication of that unverified piece of information for the rest of your assessment and for the safety of the care plan you're about to build? How does reliability of those first few cues ripple through every decision you make next? Something to think about.